We're going to be talking about urine cultures first. So we have Dr. Erik Munson from Marquette University and Heather Alvarez from, I want to say, the new name is like eluding me now that you went to Prairie. Prairie. Okay, let's get that slides up.
All right, so Erik and I are going to tag team this one a little bit. We are going to talk through urine culture workup, maybe some different case scenarios for different populations, things like that. And Erik is going to be walking around the room with the microphone, so no need to be brave and bold and walk to a microphone. He will find you. And as we go, if you have really difficult questions, ask Erik. All right. So this is kind of our brief summary of what we're going to talk about today. So some interpretation variabilities, the role that urinalysis plays in our micro world, asymptomatic bacteriuria, method and processing differences for different specimens, different patient types, some quality assurance measures, organism-specific examples, some examples of commentaries you could add to your reports to help providers in their treatment, and then some examples of different algorithms.
So the items in red are the bad news, quote unquote, or the confusing aspects of urine culture. And then toward the end, Heather and I are going to talk about some more perhaps positive ways that your laboratory can benefit from really thinking about your urine culture algorithm. So those are in green. All right, go ahead, Heather.
All right, so we're going to get you kicked off with some iClicker questions. If you've not used the iClickers before, they're on your table. You'll have a white remote. You will have to turn the power on before you can vote. So I'll read through the questions here, and then I'll turn the polling on for you. So which reflexive urinalyses are offered by your laboratory? A UA macroscopic to UA microscopic. B, a UA microscopic to culture. A C, a UA macroscopic to a microscopic to a culture. D, we offer several options of these. They might end up in culture. Or E, we don't offer any reflexive cultures based on a UA. So let me turn it on here.
So macroscopic is your dipstick, essentially, with the multicolored pads, two of which we'll talk about later on. And I'm so glad that I'm working with Heather because I don't have to futz with the iClicker at the front. I am so happy about that. Way to go, Heather. You've seen me work with that iClicker before, and it's a disaster.
I don't know how many people we have here today since it's the first one, so I'll just kind of let the numbers creep here for a little bit.
All right, 55. This is awesome.
I know.
There's no dumb answer today, especially in the first hour and 15 minutes.
All right, it looks like we're leveling off here a bit. I'm going to turn this off. And, all right, it looks like most of us offer different options of reflexes. It looks like C and D are the biggest winners there. So we do have reflexes in place based on those dipstick or microscopic results that can end up in culture. All right, next question. For laboratories that employ urinalysis reflex to culture, how's it working? We've got great. We still culture a lot of dirty urines. Providers still want to culture even though it didn't reflex, or where is choice D? So polling is on.
So I sat on the bench for a high school sports team all the time. And my brush with celebrity was I stood next to Darius Rucker before a concert, and I had no idea who it was. I'm not making that up. At the old Eagles Club in Milwaukee on Wisconsin Avenue. Circa 1992, probably.
All right, it looks like we do a lot of dirty urines, and we still are culturing because the physician wants it, even though nothing indicates.
So why don't they order it in the first place?
All right, next one. Do you have access to EHR, to the medical record, beyond what's like displayed to you in micro on your work card when you're working up those urine cultures? No, No, instead I utilize the lab system to check the urinalysis results. C, I have it, but we don't really refer to it. D, yes, I utilize it for making my micro decisions. Or E, I'm confused, it's gonna be a long day.
If anybody has comments about the polling results, speak up. I have a can of Mountain Dew on board already. I'm ready to roll. That's awesome. Oh, yeah. How many is that, 2? 4. Awesome.
All right, so it does look like the majority of us do have access, and we are using the medical record to make our culture workup decisions.
Okay, interesting. Thank you.
All right, so now we're going to kind of walk through some cases. So we'll have a little bit of patient demographics. We'll show you some pictures of culture plates, and then get your feedback as to what you would do with that culture.
There's no dumb answer here. There's no dumb answer. Please participate.
All right, so our case 1, we have a 65-year-old male in the emergency room for a fall, and this is from a midstream urine. So we have our blood agar plate up on the top left. We have our McConkeys up there in the top right, and then down at the bottom is a Columbia agar. So
CNA, gram-positive selective. Yep.
Yep. So hopefully you can all kind of see the coloration and colonies well enough on there. So we're going to go to the next one. So what would you do with this culture? A, identification and susceptibility. B, ID only. C, report contamination. D, I want more information. Or E, ask your boss. Sorry if I cut you off. All right, so it looks like most prevalent answer there is A, ID and susceptibility. Just curious, we did have some D's on there. I want more information. If you were one of the 3 people, would you be brave enough to tell us what information you would look for? Like, what information did you want to proceed?
Anyone?
There's 3 of you out there.
Bueller? Anyone? Bueller?
Nobody?
All right, that's all right.
That's okay.
We'll warm you up.
All right, so most of us in the room would have gone ahead to do the ID and susceptibility. All right, case 2. Now we have a 51-year-old male seen in urology for incontinence. This is a urine from an indwelling catheter. So there we've got a lot of growth, mixed colony types on all 3 of our agar plates.
And I think there's going to be a close-up of the McConkey on the next slide.
I think you are correct.
Yes.
Yep.
Now, you may not be able to see it here, but there are 2, in my opinion, 2 types of hot pink
here.
colonies.
And then
in
there's
addition
a clear
to
one.
the non-lactose fermenter.
Yep. All right. What would you do with this one? ID and susceptibility, ID only, contamination, I want more information, or again, ask for help.
What kind of a catheter was that again, Heather?
Indwelling
Indwelling
catheter.
catheter. Okay,
from
thank
urology.
You. Thank you.
All right, so we have majority of the room calling this contamination. We do have some 9 respondents there saying they would do the full ID and susceptibility, 4 ID only, still some that want information. And we have 1 phone a friend there. Anyone willing to share? So I come from a facility, a rural hospital. There's a lot of you in the room. That's nice to see. We don't have urology. I'm kind of glad we don't have urology when I come to these conferences. So I'm just curious for maybe some of the difference here. Is there a difference because it's a urology sample versus a non-urology sample?
That's interesting.
Thanks. So I chose D. I need additional information. I would want to know if the patient was a pre-surgical for a urology procedure. In that case, we would work up ID and do a susceptibility on the potential pathogens.
Okay.
If it wasn't pre-surgical, I'd probably mix it.
Is that philosophy in response to, say, a urology physician request to do something like that? Okay. Erica? I'm sorry, Eric.
I actually said A sarcastically because I knew urology would call us back and tell us to work it up. my real answer would have been C, so that was where one of them was.
And that's why Heather's glad she doesn't have urology at her hospital, right?
That's correct.
Yeah, we were in a similar camp as Erik. They just call and ask, or unfortunately, like a patient would get a procedure canceled sometimes too. So we actually worked on a project with urology. They have 2 separate orders they can order. So they can order the one where we work everything up for them if it's a pre-surgical, or they can just order a routine that we work it up like any other routine.
So it's essentially a pre-surgical requisition versus a routine requisition. Okay. Mr. Cram.
Sorry, just a question to Gina. Would you just give identifications only, or would you do sensitivities for everything as well? Okay, thank you.
All right, keep it up. This is great.
All right, so this is what got reported from a laboratory based on the culture we just looked at. So we had greater than 100,000 mixed type gram-negative rods, no further workup performed, Foley cast specimen has more than 3 organisms, suspect colonization, recommend changing the Foley prior to recollection. Another option reported by a laboratory, greater than 100,000 organisms per mil, mixed contaminants. So kind of in line with the majority of how you guys had voted that you would report this out, but no answer is wrong.
Yeah.
All right, case 3. We have a 65-year-old male seen in the clinic for confusion. Midstream urine. And here's our plates.
CNA's on the upper right on this one, apparently. And there's a super close-up of your McConkey plate, duh. Appears to be mixed.
All right, what'd you do with this culture? ID susceptibility, ID and susceptibility for the gram-negative rods, identification of the negative rods, contamination, or ask for help.
Is the CNA supposed to be pure?
The CNA, was the CNA pure? I think it was. Can we go back? Oh, boy.
It appears so from here. I don't know. Not all of them show the alpha hemolysis.
Let's call it mixed.
Yeah.
Let's call it mixed. My bad. So there's a couple teeny tinies in there that we can't see from row E, or row A for that matter. So CNA looks like it may have greater than 100,000 mixed gram-positive flora. Good question.
All right, we've got report out as contamination as the majority there.
Okay.
We do have some ID susceptibility
Yep.
for everything, and we have some ID and susceptibility of gram-negative rods
Looks
only.
like some of the folks are focusing on the gram-negative rods.
Correct.
Okay, that's fine.
Just a show of hands, how many of you set up a CNA on your urine cultures?
That's a good question.
We do not.
Yeah.
If you have your hand up, could you just tell us a benefit? Like, what is the helpfulness of that CNA?
This is a chatty group right here.
So it depends. We only set up CNAs on indwelling caths and straight casts.
Okay.
So on clean catches, we only do blood and McConkey.
Anybody else?
Sure.
We would set it up on our spinal cord injury patients and GU
Genitourinary, GU.
or GI or no GU, like yeah, urology.
Oh, same thing to me. Okay.
You
So
got
it
another hand
depends
behind
on-
you, Eric.
Oh, sir.
We use CNA more as a backup, not initially when using McConkey and blood. So if we have someone with Proteus and we can't tell if the sample's mixed sometimes or if there's a predominant gram-positive, we will then set up the next day a CNA with an alcohol pad that kind of prevents swarming.
So not in a primary situation, but in a backup situation. Fair enough. Anybody else? Yes?
Just make him keep running.
That's great.
Right. So sometimes we get cultures from other labs to read, and they set up with a CNA, and it is helpful for us when determining what the problem is, because we don't get that on midstreams. So sometimes it works in our favor when you can see what the underline is on the CNA, where if it was all GNRs, it would probably cover it up. So it's cost and time and plates, but it really is helpful.
Thank you.
Thank you very much. Oh, Brooke.
I was going to kind of say the same thing, is that we recently went from having, within like, I don't know, well, like a couple of years, going from having the 3 plates to just having the blood and McConkey, and it seems to me, from making that switch, is that we do a lot more susceptibilities on gram negatives that we may not have needed to have done if we were able to see underlying that it was actually mixed, especially if you have something like a Proteus or a Kleb that's completely covering everything. That's just been like my opinion, and there's been times when I'm like, I really wish I could see what was going on here.
Yeah. Especially probably if you have a low count of gram-negative rods. Yeah, that's a good point. That's a good point. All right.
Thank you.
Same
right.
culture.
Same culture. So now we're going to, this is some of your results from your
Urinalysis.
and urine micro. So
Yes.
no nitrites, moderate leukocyte esterase, 6 to 10 epis, too numerous to count on your white cells on micro, and 3+ bacteria.
So that's relative to the previous
So now that
set
you
of
know
plates.
that,
Yep.
would you do something different with this culture? ID and susceptibility for all isolates, same options as before. ID susceptibility GNRs, ID of GNRs, still report as contamination. So if you had the UA in front of you and the microscope to look at, tell us what your response would be now.
Would it change anything? Because a lot of you noted in the iClicker workups that you do look at the electronic health record. It seemed like a healthy proportion of you folks did that.
You know the provider's going to look at those UA results and say they have an infection, right? All right, so we still are reporting out as contamination.
Okay.
Looks like a little bit more of them focusing on those gram-negative rods than before, but
Okay.
still majority contamination. Case 4, 65-year-old female in the clinic for dysuria, midstream urine. So our CNA is again down there on the bottom.
Yep.
I don't know if you can see the McConkey. There is some whitish stuff on
Looks
there.
like
It's a little-
non-lactose fermenters.
Yeah, a little bit hard to see maybe depending on how far away you are.
And I think those are struck in semi-quantitative fashion, in quadrant fashion, not necessarily, the McConkey was, not streaked in colony count fashion, just to be completely clear.
All right, what about this culture? ID susceptibility of everything, ID of your negative rods, nothing major because the colony counts are low, contamination, or ask for help. Clinic patient, dysuria, midstream urine.
Gesundheit.
All right, so it looks like the majority of us are doing contamination or no workup because the colony account is too small. There are a couple up there who are going to ID and sense everything, or the negative rods. All right, so now here's our urinalysis results. No nitrites, moderate leukocyte esterase, no EPIs, 11 to 20 white cells on microscopic, 1+ bacteria.
Same culture.
Same culture. Your patient did have symptoms. This is their UA. Now what would you do with the culture? Same options as before. All right, we have a lot more now who are going to work up those negative rods. That bar was much lower before. Still a lot of low colony count and contamination. Anyone want to share why you'd work it up? Those of you who are going to do an ID of those negative rods.
No wrong answer.
It's very possible if you pick the bottom ones, they're going to call you and
thanks,
tell you
Tim.
to work it up, right?
Excuse me.
We have a comment that we put into ours when we have about this many gram negative rods. It's just to notify us if they want it worked up. Otherwise, we don't do anything. Unless it's E. coli, we'll rapid ID those sometimes.
Thanks, Rio. All right.
Thank you. And just as a side note, this patient was treated with ciprofloxacin. Even if we didn't work it up, they were treated as a UTI with Cipro. All right, so we're going to talk a little bit about the role of urinalysis. We've kind of given you some UA results. So urinalysis results can help determine if there's indication of a urinary tract infection, right? Providers are mostly looking at the nitrites, the leukocyte esterates, maybe the blood, bacteria. And as textbooks would say many years ago, a positive UA tells you there's an infection, right? Doesn't anymore. So
should I take over on this one?
All you.
Right. So when looking at the literature on this topic, there's been a lot of, for example, that JCM reference is a point-counterpoint publication relative to UA reflex. And they show in that article that even if you have pyuria, which is defined as white cells or sometimes even leukocyte esterase in urine, the positive predictive value for a leukocyte, even a leukocyte finding, is very low, right? So it's not gospel that this person's going to lead to a significant urine culture finding. And then in general, if you add other analytes, such as your nitrite result to your analysis, overall the predictive value is probably less than 50% in some literature, right? So we kind of gave those examples to see if a UA result kind of influences a tech to perhaps change a report. And it looks like it did in some of the instances, especially if you have gram-negative rods. But when you look at the literature, a lot of the UA data is not terribly predictive in a positive predictive value sense. Next slide. All right, so when I was director, we did an audit of UA reflex practices as far as how they translate into significant culture findings. And this was a wonderful project for two of our younger techs. They looked at over 3,500 UAs that ended up resulting in a urine culture. And before that, our laboratories standardized the urine culture interpretation procedures, so it was much more, standardized. I'm being redundant, but everybody's interpreting urine cultures the same way, right? Then we assessed what happens as far as UA reflex. So then we came up with a scoring system at the bottom because there's lots of schmutz in these cultures. Everybody knows this. So one scoring system would be if you had a pure culture pathogen, nothing else in there. Score number 2 would be a predominant pathogen that's probably about 10 times the quantity of your contaminants, and then a third category in which your pathogen equaled the contaminants. So that was a little bit more nebulous as far as interpreting data from the laboratory perspective. Next slide. So we termed the first 2 as being stringent criteria. I mean, that was like almost like a slam dunk for a UTI as far as a laboratory diagnosis is concerned. Then if you add the third one, next slide, Heather, then if the pathogen equaled the contaminants, we called that a less stringent criteria. So we looked at and then there's our god-awful flow chart that we used back in the day, and some of you probably have nightmares from looking at this, some of my former techs in the front row. So number 1 and number 2 in green are the more stringent slam dunk. This is probably a UTI situation, and those are situations in which you have greater than 100,000, and it's a single pathogen or probably no more than 2 potential pathogens, right? And then number 3, where we're using less stringent, we're not so sure about this one, those are the ones that tend to have more contaminants intermixed with it. So those are the criteria for establishing what we're using as a reference positive urine culture. Next slide. And this flow chart is based on the Clinical Microbiology Procedures Handbook, which has a new edition that came out last year, I think. What is it, 4th or 5th? I think it's 4th. 5. We have an author right here, right? So that's the 5th edition. Al knows everything about that. So that's essentially the basis for generating this god-awful looking algorithm for working up a urine. It's based off of ASM and clinical microbiology literature. Next slide. So here are the data. So first of all, looking at nitrites, all right? So a positive nitrite result, and remember all of you back in school, Enterobacterales reduce nitrates to nitrites, right? So you have a nitrite in there, it could be an Enterobacterales causing your UTI. So using the stringent criteria in which it looks like a laboratory slam dunk culture for a UTI, a positive nitrite result resulted about 70% of the time in a significant microbiology finding. Not great, but better than some of the stuff you're going to see in a couple of slides. If you added the equal contaminants to equal pathogen, we're increasing that predictability to about 80-ish%. Now, in situations, we have significant microbiology findings about 25% of the time with a negative nitrite result. Anybody know which organisms play a role there? What are your nitrite negative urine pathogens? Probably Enterococcus, which doesn't touch nitrates to begin with, and Pseudomonas, which takes it all the way to nitrogen gas, right? So those infections would be missed if you're relying on nitrites as a predictor. Next one. Leukocyte esterase, all right? And in some systems, this is viewed with the naked eye. There are some instruments that can also, give you a result of negative versus moderate versus large based on the amount of purple in there. But look at the predictability of a positive leukocyte esterase result. Much lower than what it is for nitrite results, right? So in my view, if technologists are viewing this as a criterion for guiding their workup, you may need to consider differently, right? Because it's not always predictive of a significant microbiology finding. Even if you add the contaminants in with that, that's fine. So it has to be really large amounts of leukocyte esterase in our experience to have more predictive value. But still, again, you're talking about 1/2 to 2/3 predictive value. Then the next slide. So if you're going to the UA and you really want something to sort of hang your hat on besides nitrites, it's the leukocytes within the microscopic examination. And even in that situation, you're looking at probably 50 or more, or even 100 or more to get you to about 2/3 positive predictive value, essentially, or 3/4 positive predictive value, right? So be careful when my advice is to be careful when if you're in the practice of doing that. Next slide. All right, so this QA project stemmed from the fact that the UA department in our laboratory was interested in changing the UA reflex criteria, right? Everybody's probably done this before. So past reflex criteria included a positive nitrite test, which would probably grab your Enterobacterales for the most part. And then another option was any semblance of leukocyte esterase plus a microscopic finding of at least 5 WBCs, and then observation of bacteria, any bacteria in a cath urine. Those were all parameters that could result in a reflex to culture. So in the old days, in the old reflex culture, the predictability of a positive nitrite result, again, was between 70 and 80%. That mixed criteria that you see in the middle as far as microscopic and macroscopic only got you about 50% predictive value as far as a significant microbiology finding, right? So again, evidence that we sometimes maybe should watch ourselves when relying on UA results in making our culture decision. And again, this is not a guidelines day. It's not a guidelines day. That's just me going on my soapbox about that. And then as a result, next slide. So we showed our pathologists the information, and revisions were made. The nitrite was still in existence as far as an automatic reflex, but then we moved to moderate to large leukocyte esterase. I was really cringing when our pathologists wanted to do that, but I'm not the medical director of the lab, right? So we elevated those criteria from any amounts of leukocyte esterase to moderate to large, and that got us slightly over 50% as far as predicting a significant microbiology result. And then the one I was really battling the pathologist on, and she was a great pathologist, great medical director, and I just could not convince her to go any higher than 25. So she was going with 25, and that led to about 2/3 predictive value for a significant microbiology result. I wanted to go all the way and go to 100, but she wasn't comfortable with that. All right, next slide. So in general, if you look at the literature, probably the better or the bigger bang for the buck as far as UAs relative to reflex culture is in a negative result, right? There's far more negative predictive value when everything on that UA strip and everything microscopically is negative, as you can see from the data there. So in a low prevalence ER setting, if everything's negative, there's probably a 98% chance that your urine culture is going to be negative. And I think some labs use that as a reason not to reflex. I've seen that before. In a higher prevalence setting, you're seeing data in the 90%. And again, these are all negative values for bacteria, leukocyte esterase, nitrite, and less than 10 white cells. And those are 90% predictive for having an insignificant culture finding. All right, I'm done for now. Go ahead, Heather.
All right, so we're gonna jump to the iris here for a little bit. So another iClicker question. So if you use an iris...
Excuse me, Heather, Ray has a question.
Yeah, I do.
And you can ask Erik.
You know, I just have a comment. You know, if you touch a little bit in the infection prevention world and surveillance definitions for urinary tract infections, you know, it's symptoms, costovertebral angle pain, pain on urination, frequency. Never do they look at nitrites, leukocyte esterases, bacteria.
Absolutely.
And, you know, looking at the, you know, a urinalysis, you know, you have someone with asymptomatic bacteria, they're going to be positive in all of those.
Absolutely.
I think you're feeding into the rest of our talk quite nicely.
And so, you know, when you do these kind of studies, did you look at symptoms at all in those people? Or are you just looking at a colony on a plate? You know? So that was just my comment.
Like Heather said, you are segueing into the rest of our presentation. So an experienced microbiologist like you knows the big picture. So thank you very much for that, Ray.
All right, so if you use an iris for microbiology, what is your threshold for bacteria being abnormal? So at what level on your iris do you call it abnormal? Trace, 1+, 2+, 3+. Is an iris a member of Kingdom Plantae?
Raise your hand if you use an iris. Oh. Okay. Maybe we'll skip this one and go right to Megan. Let's do that. We'll save some time here.
All right.
But thank you for your participation, though. All right, I'll take over for a little bit, and actually I'm going to let Megan Selly take over for a little bit. So this is, I think, Karen Siebers sent me these pictures. So does this look like what you have in your laboratory? Why don't you describe what an iris is? Megan Selly, by the way.
Well, I wanted to put a disclaimer in. I work strictly in microbiology, and our iris is done out in the core lab. But it's just an automated instrument that does an automated UA and microscopic, so we don't do any manual microscopy for urinalysis anymore. For just our hospital, our regional medical center lab, all of the other critical access labs and clinics still do a manual microscopic.
Does that picture ring a bell to you?
No.
Okay, we'll skip that one. Okay, so here's some primary literature that revolves around an evaluation of the iris, and basically, from my understanding, I've never used this one before, they look at a variety, three major parameters, I think. They look at something called bacteria, they look at leukocytes, and then they look at something called ASPs, which are like all small particles or any small particles. Those are some of the parameters that they use. And in this paper, all the minutia on the bottom is establishing optimal cutoffs, right, for what's going to be reflex. This is a study on how the iris does as far as reflexing urines to an insignificant or a significant culture finding. So just ignore that stuff that they're establishing, they're receiving operating characteristics, stuff like that. So in this paper, they essentially compared the iris parameters, which you're going to see in blue letters toward the center of the table, comparing it to common parameters like the UA, right? The UA stuff is in red, the iris stuff is in blue. And so they modeled their system for 95% sensitivity, and then they calculated specificity. So specificity is essentially kind of their predictive value. What percentage of their iris reflexes are going to end up in a significant culture finding? And remember, Megan said that this is an automated instrument kind of doing the work of the UA for you, right? So importantly, the all small particles plus the bacteria plus the leukocyte combination, if all three parameters were significant findings on the iris, that had the highest specificity, or in other words, the highest significant reflex rate at about 61%. But perhaps more important, especially in light of our previous couple of slides, where we talked about the negative predictive value of your leukocyte esterase and whatever, the negative predictive, or the negative aspect of this, which is actually a good aspect, is that 35% of the iris negatives ended up in no culture setup, right? So it eliminated the workload by about 35%, or based on an iris finding, you didn't have to reflex to culture in 35% of your situations. So next slide. Megan was nice enough to share some of her data from her laboratory, and I'll go through it quickly and then I'll let Megan comment on it. So there are people in urine theta care, right, in Fox Valley area extending west. There are folks in her laboratory system who do not use the iris. They use iris just in Neenah, right? Right at the main hospital in Neenah. So other folks in the healthcare system not using irises, for 2 months they had about 2,000-ish UA reflex orders, or they had test requisitions that wanted the UA plus the reflex if significant, right? So about 30% of the time, there was a significant finding on UA to promote a reflex, okay? So what Megan did was, in her laboratory, she uses the iris, looked at 585 cultures that wanted the reflex, and she applied that 30% value in non-iris situations to her number, and that 30% times 585 is about 175, or yeah, 175-ish, which means that if she set up 140 cultures, she didn't have to set up 35 cultures, right? So 35 out of 175, she eliminated 20% of her culture setups using the iris system. And in a lower N value, which is here, that's sort of on par with that 35% that we saw in the primary literature in the JCM article. And even with that 20% reduction, there was no significant difference in the amounts of pathogens or proportions of pathogens she found in her iris situation versus non-iris situation, and the contaminants and the no growth values all had p-values greater than 0.05. Any other comments about the iris in your setting?
Just one comment. We only went live with a UA reflex to culture order in late December, so I only had about 2 months of data to go off of, and it's not being utilized as much as we would have liked. It's only being utilized 30% of the time, which made our numbers even lower. They're circumventing and going back and ordering the urine culture on the back end.
Sneaky, aren't they? Yeah. Any questions about the iris or comments about the iris? We have one over here.
So we're at the VA Madison. We have kind of a different patient population, mostly old men. But we are iris users, and we have had this reflex in process since like 2016. And this tracks. We consistently cancel about 30% of our urine culture orders.
So that matches up with the literature pretty well then, and Megan's Day as well. Wonderful. Any other thoughts or questions about this before we move on? Okay, go ahead, Heather.
All right, next case. 81-year-old female, seen in the ER for shortness of breath, congestive heart failure, midstream urine. So here's our plates. You'll see from that arrow there that McConkey's plate was subcultured to the one that's split down the middle. So you have the 2 McConkey's plates, the blood auger on the top left, your CNA down at the bottom. A lot going on. What'd you do with that culture? ID susceptibility of everything, ID susceptibility gram-negative rods, ID of your negative rods, contamination, ask for help.
Pay attention to the clinical situation in these next 2 or 3 cases.
We haven't used the clickers for a little bit, so just make sure your clicker's turned on too. Sometimes they turn off after a while. All right, so it looks like we have 21% contamination, well, 55%, 21 people, and 13 people doing an ID and susceptibility for the negative rods. Here's our urinalysis, negative nitrites, small leukocyte esterase, 6 to 10 epis, too numerous to count on our white cells and microscopic, and 3+ bacteria. This patient was treated with ciprofloxacin for UTI.
Probably based on the culture results, what was reported. Yep.
Correct. Case 6, 90-year-old female, seen in the ER again for a seizure, midstream urine. Got a lot going on in this one again, too.
Doesn't look like much on the CNA plate.
No. What do you do with this culture? Same options as before.
Just a quick question, Heather. Did either of these 2 patients have any symptoms
I
of a
think the
urinary
first
tract
one had a
infection?
seizure, or this one had a seizure, and the first one...
The first one was congestive heart failure and...
Shortness of breath.
Shortness
Thank
of
you.
breath.
So no localizing signs and symptoms of infection?
Exactamundo.
Correct.
Both of these are asymptomatic bacteria.
Exactamundo. Yes, Ray.
Ray was not paid to feed into our presentation.
And Ray is not a paid endorser of treating asymptomatic bacteria either.
All right, so 70% here we're doing an ID and susceptibility of the negative rods, 28% mixed contaminants.
And we're not dissing anybody because when we get the requisitions, we don't know. A lot of times we don't know the symptomatic or asymptomatic status of the patient, right? We're just asked to do the work. This is where we run into trouble sometimes.
Here's our urinalysis results. Little bit of bacteria on the microscopic, not many white cells. Again, treated with ciprofloxacin as a UTI most likely. Case 7, 77-year-old female, seen in the ER for weakness, fatigue, midstream urine.
Doesn't look like there's anything on McConkey.
Nope. Similar options to before, but this time gram positives instead of gram negatives. All right, we got quite a mix in A, B, and C there. So
But we had some people identifying, correct?
we did,
At
yep,
the very
quite
least.
a few.
Okay.
Yep.
Great. Holy cow, look at all those leukocytes.
All
Now
right.
what do you do? Same culture
Same.
findings, ton of leukocytes on the UA. Microscopic, I'm sorry.
But only like 21 on microscopic.
Well, that's true. That's more than 3 to 5, yeah. That would qualify under the new reflex criteria.
Still working these up.
So we have some more people dipping their feet in the pond.
Yep.
Brooke.
So I have a question just kind of based on something that we do like recently in the last year or so. Apparently our pharmacists have said that even if we have a pure culture of over 100,000 coag neg staff, that we should not be doing identification and susceptibility on it, which quite a few of us feel heebie-jeebie about. If it's a woman of childbearing age, we would do a MALDI to rule out SAPRO. We would, so we would identify that, and then we've got like a canned comment that we put in for that, about susceptibility. But yeah, so even if it's a patient with like over 100,000 coag neg staff, we're not supposed to do susceptibility, and some of us are kind of like, even on like a cath urine. So I'm just wondering if other people.
Yeah. Anybody want to comment on that? Do we have that situation in other laboratory locations? Being advised by pharmacy not to work up a pure culture coag negative staff. I think they may be going after what we're going to talk about in a little bit, perhaps.
Yeah, when I train people, I tell them that older men usually have that, so, and we have to work it up.
Yeah. All right. So this, as Ray predicted, we use predict a lot today. As Ray predicted, we're going to delve into the topic of asymptomatic bacteriuria, right? So there was a recent review published in CID a number of years ago, 2019, that gives a whole, you can't read it obviously, and I can't read it either, but there are certain patient demographics in which they, like Jordan said, they just have stuff in their urine, right? So if you really look closely at the pictures here, or the figure here, we have women in the community over the age of 70 have a higher percentage, and elderly persons in a long-term care facility, sometimes up to half of those individuals have what is called asymptomatic bacteria. So again, it's greater than 100,000 in the urine, but they're exhibiting no altered mental status, no flank pain, or any of that stuff that indicates a UTI. Next slide. So these folks may, in addition to having greater than 100,000 in their urine, they may also have pyuria at the same time. Remember, they're asymptomatic. They're having seizures, there's shortness of breath, like congestive heart failure, like Heather mentioned before. So those folks, asymptomatic, have tons of bacteria in the urine. They may also have white cells in the urine as well. So, that's a potential, another thing to think about when relying on UA results as far as your urine culture workup. So young women can have pyuria about a third of the time. Folks in long-term care facilities or hemodialysis patients can also have pyuria quite a high frequency of the time. And the simple bacteriuria does not either tell you it's contamination or asymptomatic bacteria, right? So again, be mindful that it could be asymptomatic bacteria, but of course, we don't know that half the time, right? Because we're not guided on symptomatic status of the patient, right? So Ray's probably getting at, why are these going to be ordered in the first place, right? That's the biggest thing. This is a front-end type of thing that sometimes the laboratory doesn't always have control of it. Now, I have colleagues at Medical College of Wisconsin, pharmacists, who are working on projects to try to get physicians to more appropriately order urine cultures in the realm of potential asymptomatic bacteria. So there are measures being taken at some facilities to try to curtail this process. Let's see what this slide is about. This is a study published very recently in CID from a group in Europe that looked at pyuria cutoff. So again, pyuria is the presence of white blood cells in the urine. And in many scenarios, the cutoff for a significant UTI was at a cutoff of 10 leukocytes per mil. So what these folks did in Europe was they came up with two groups of patients, both of whom are women over the age of 65. They divided them into a UTI group, individuals who had at least 2 lower urinary tract infections, about N value of 63. They all had one pathogen at greater than 10,000 per coliform units per mil. Then the control group was another set of women who were absolutely asymptomatic for urinary tract infection. So some of them did have a pathogen at greater than 10 to the 5th, right? So that's your asymptomatic bacteria, so they're kind of killing two birds with one stone. They're looking at asymptomatic bacteria, or a little bit in here, and others had a negative culture or, in general, no significant findings. Next slide. So this will be impossible to see from where you're sitting in row E and back, but they looked at microscopy methods and flow cytometry methods to assess the number of white cells, right? So the N values are given, and then underneath those are interquartile range and median white cell counts. And the researchers show that in the UTI group, the pyuria counts, or the white cell counts, were significantly higher than any of the counts in the control group. So we're talking about 1,000-ish or 1,500-ish as far as a pyuria count in the UTI group. When you get to the control group, we're seeing stuff like 6 and 20. The asymptomatic bacteria folks had about a median white count of 200. So the researchers are arguing here that higher pyuria might be more predictive of a UTI. But they also state in the data that asymptomatic bacteria folks in that ASB column can also have pyuria counts that increase. So then they stratified their diagnostic strategy by actual pyuria counts. So you see 10 white cells per microliter, 50 white cells per microliter, and then they look at specificity values. And again, the specificity value is how predictive is your white count finding of a significant UTI. And the numbers are quite low in the specificity when you get to 10 and 50, and they probably start optimizing when you get to about 200 and 300 white cells per microliter. So they're arguing that cutoff of 10 white cells per microliter is too low as far as really trying to rule in a urinary tract infection, especially in folks who may have asymptomatic bacteria. I think it's your turn, Heather. Oh, I'll finish this one. So to reiterate with what Ray said, right? Diagnosis of a UTI requires bacteria as well as symptoms. And I think Heather's going to give you a laundry list of symptoms that are far more compatible with the UTI than seizures and congestive heart failure and stuff like that. So in a past CID study, they mentioned that screening and treatment for asymptomatic bacteria is pretty much off limits, except for two demographics. Number one, pregnant women. Treatment of asymptomatic bacteria may be indicated in those folks, as well as individuals undergoing urologic procedures. So that may fit in with what your urologists are saying as far as working up your urine cultures. Next slide. So a more comprehensive or more contemporary study regarding asymptomatic. In this paper, the researchers or clinicians give a whole laundry list of demographic factors or populations in which there's no strong evidence to support workup and treatment of asymptomatic bacteria. So they expanded the list, right? They actually iterate what that listing is. And then in high-risk neutropenic patients and time of indwelling or catheter removal, there are no concrete data to make a recommendation at this point for the management or treatment of asymptomatic bacteria. So there are guidelines out there guiding when not to manage these people with antibiotics. All right, now it's your turn.
All right, so we're going to look at the pre-analytical side for just a little bit here. So ideally, urine culture should only be done when the patient has symptoms compatible with a UTI, so fever, frequency of urination, urgency, dysuria, suprapubic tenderness, altered mental status in that elderly population. But up to 50% of urine cultures that are ordered in the ED or internal medicine are from patients without symptoms. So if you have medical record similar to mine, I can see a diagnosis on all of my cultures, right? I can see the diagnosis applied, but to find symptoms is very difficult. I mean, I could dig into the chart and find them, right? But we don't always know if the symptoms are there or not. So what are acceptable specimens? So we want them to have symptoms. That's kind of where we want the providers to start. Acceptable specimens for a urine culture, a midstream clean catch urine. They might say they're midstream clean catch on the order. We don't always know if they actually are clean catch. Again, catheter collection. We only have the information that is put in the order in the EMR. It doesn't mean the patient followed the directions or was done correctly. Suprapubic aspirations are acceptable. We should not be culturing Foley tips or urine that was sitting in a catheter bag, fermenting. And then there will be some workup caveats we will talk about a little later. Literature, your urine's good at room temp about 20 minutes. After that, you want to put it in the fridge up to 24 hours. Some literature says it can be in the fridge for 48 hours without affecting your urine culture results. There are some sites that add boric acid as a preservative. So what I could find in JCM there, it is equivalent to refrigeration in preventing bacterial growth. Although if you're using that for your urinalysis, the boric acid can affect some of your chemistry or urinalysis data, and it may not be compatible for molecular type tests if you need those done on your urine.
Yeah, if you're a Panther user, you can't aliquot boric acid urine into a hologic tube for STD analysis.
All right. A QA question here. Does your lab do quality assurance monitoring of urine culture contamination or no growth rates? We track contamination rates. We track no growth rates. We somehow have the time to track both of these. And then questions for the rest of you who don't want to pick the first three.
We still have people awake. This is good. The numbers are tallying.
I've heard a lot of talk in the molecular world, right? People checking contamination rates of your molecular type equipment.
Yep.
All right.
Oh, you just wait. Just wait.
So not many of us are tracking urine contamination rates or urine no growth rates.
There's a coup against you, Heather. There's a coup forming.
What cutoff do you use for colony counts in pediatrics? So if you're working up a pediatric culture, 100,000 CFUs per mil as your cutoff, a lower of 50,000, we report anything. I want to know what a specialist does. I've had it up to here with my own kids. I don't want to deal with other people's. Oops.
Oh, yeah.
I know we've got
Do we have a children's hospital in the house? Yes? Shout it out. What do you use? What's your cutoff? Shout it out.
We do up to 100,000.
You do 100,000. Okay. Are you children's in Milwaukee? Yes. That's what I thought you did. Yeah.
All right, so for the rest of us, their cutoff is 100,000 at the Children's Hospital.
Thank you. All right, so Aaron Bowles led us to this paper. This is a recent publication in Pediatrics in which this group, I think it was United States, is advocating for potentially a lower cutoff for significant urine culture. I'll stand out of the way. So in this study, they looked at 341 kids with fever. The age range was very young to about 3 years old. The average is about a year old. And they used fever essentially as the indicator for a UTI because obviously your little 2-month-old really can't tell you if they have back pain, or your person in diaper can't tell you if they have blood in your urine or anything like that. So they use fever as the parameter or indicator of significant urine findings. So they compared conventional culture to 16S ribosomal RNA sequencing. They used the sequencing as the reference method, or the gold standard method, right? And the parameter within the sequencing, they're looking for 80% relative abundance. So as you know, especially in dirty urines, quote unquote, we can have a big mixture of bacteria. And the no UTI group is on the far right of that colored picture, and you see all the different colors representing the whole gamish of schmutz-type organisms in those no UTI cultures. And the researchers are making the point that in the UTI cultures that you see in the column there, by the way, the yellows represent E. coli's, the blues represent Klebs. When you have those in a UTI situation by ribosomal RNA sequencing, it's a pretty much predominant, quote-unquote, genomic picture, right? So there's not much, evidence of contaminations. There's very strong relative abundance here, right? They also looked at inflammatory markers in urines. The cutoff point was 10 for pyuria, even trace esterase, looking at any kind of esterase, and lipocalin is another chemical that indicates inflammation. So next slide. So this is almost impossible to cut out or see, but there were 46 individuals, as we mentioned before, with UTI, and if you look at the top data, when the cutoff of 10,000 in conventional culture was used, they found or identified 45 out of those 46. With traditional parameters of 100,000, they only found 32 out of 46 with the UTI. So based on the ribosomal RNA reference method, that was their justification for proposing a much lower cutoff for significant UTI at 10,000. And when you look at the middle column, as indicated by the arrows, in that 50,000 cutoff, there were 9 total misses, which is thrown into table 3 that you see down there. And the researchers show that there were significant inflammatory markers, either by white count or by that whatever chemical I mentioned before, and they all correlated with E. coli or Kleb identification. So 2023 publication may have some influence on what is done at pediatric facilities in the future, perhaps.
All right, throw in another case study here. 85-year-old female in the ER for altered mental status, so one of the symptoms on our list, from a straight cath urine. So here's our culture plates there. As referenced in the title, have you ever heard of Erococcus urinae?
That's what was on the CNA plate,
That's what was on the plate, yep. So, yes, I've heard of it. Yes, I'd love to tell you about our experience with it. I don't really know what it is. No, I don't know what it is, and I don't want to hear anything more about it. Actually, you meant Eromonas.
What do we know about Erococcus? Oh, our bladders are in pretty good shape right now. That's good.
Yep. So it looks like most of us have heard of this before, probably seen it in our laboratories.
So this is like grandma's UTI, right? We see it usually in like 60-year-old, 70-year-old, 80-year-old women. So I teach it to my students as grandma's UTI. So this is a lead-in to the CLSI M35 document. This is the rapid identification document put out by CLSI. BTW, this is under revision. The CLSI has started revising this document. They started doing this in January. So there will be some changes to this document. Next slide. So within the current version, there's only mention of Erococcus viridans as a specific line item that you can identify in a quickie type of fashion. Next slide. Erococcus urinae is sort of hidden in the viridans group Streptococcus recommendations as far as quickie identification. And that's one of those strep wannabes that gives you a catalase negative result, but it shows up as clusters or tetrads in your gram stain, especially if you do your gram stain off of broth rather than the colony. So that's where that organism fits in. I will tell you that Erococcus urinae is going to have its own separate line item in the CLSI M35 revision. So it could be more accessible to laboratories to try to identify in rapid fashion. Next slide. Go ahead.
All right, case study, 26-year-old female seen in the clinic. There are no symptoms noted. Midstream urine. So here's
I think there's a close-up of this one.
I think so too.
Yeah.
Yeah, doesn't
And that
come
is-
through real clear.
And that is very weakly beta hemolytic, supposed to be.
Yes. So we're looking at our strep agalactia there. So disc diffusion testing performed on our strep agalactia. What do you do next? So I know not all of us do this, but if you do disc diffusion, we have a hand up already.
Is the patient allergic to penicillin?
The answer is yes. They are allergic to penicillin and OBTW. That was an OBGYN clinic. Thank you, Brooke.
Are you reporting your erythromycin after a D-test? Reporting clindamycin after a D-test? We report neither one of those. We report both of them, or we're going to call the OBGYN office. I'm guessing our numbers here will be a little bit lower.
Oh, we have iClicker. Oh, dear. It's going to be a long day for you. No iClicker.
All right, so not many A responses there. So we have some reporting Clinda. That's B, right? Yep. Some reporting the clindamycin, report neither one, or report both.
Okay. This is interesting. This is kind of what we call in academia a trick question. So Group B strep guidelines are no longer published by the CDC as they had been for the first 3 versions. They're now under the auspices of ASM. So the Clinical Practices Committee of ASM is now in charge of publishing your Group B recommendations, right? They've upped the screening time point to 36 to 37 weeks to account for those late deliverers, the ones who want to keep their child in a little bit longer. So that's why they upped it from 35 to 36 weeks. Prophylaxis recommendations have changed a little bit. Penicillin/ampicillin is still the go-to, but if a patient is noted to have a non-severe penicillin allergy, cefazolin can be recommended. But again, if there's severe allergy, then clindamycin is the option. Pending, of course, susceptibility testing, right? Because a lot of us know that our clindamycin susceptibility rates against Group B strep are not great, probably about, 50, 60%, right? So there's a pretty strong possibility that that could happen. Next slide. So within the recommendations, reporting Group B in any quantity from urine cultures, we're doing a urine culture here. So a pregnant woman, urine culture during any trimester, it's pretty much automatically reportable. And there is some literature suggests that high colony counts of Group B when a patient is symptomatic could lead to adverse pregnancy outcomes. And of course, if you're low colony count, that earns them intrapartum prophylaxis during delivery, right? So, and as Brooke mentioned, we need susceptibility testing on patients with severe penicillin allergy. Next slide. All right, then we get to CLSI, right? So CLSI weighs in on this. And if you look really closely here, and I'm going to have to step a little bit closer, we need to do, at the very minimum, erythromycin and clindamycin susceptibility testing, but we only report what? Clinda. We only report Clinda. Why are we doing the erythro? A D-test, right? Remember CLSI says you do a D-test on staph, beta hemolytic streps, and strep pneumos, right? So you're only putting erythromycin in there for the purpose of checking for inducible clindamycin resistance. We do not report erythro because those resistant rates are even worse than our clindamycin resistant rates for Group B. Next one. But then you get into the situation where you get to one of our table, they change the name of these tables, and some idiot's going to tell you about that next week. So they change the names of these tables, and the tier 1 drugs include clindamycin for the beta hemolytic strep, but then there's a little superscript that says not routinely reported for organisms from the urinary tract. Remember, drugs like erythro, clinda, and I think there's always one other one that I can't remember, do not penetrate the urinary tract, right? So we have a lady with Group B strep. We're testing the right drug as far as, intrapartum prophylaxis. But what do we do with this result? Do we report it? Because clindamycin should not be reported on urinary tract isolates. Any thoughts from the peanut gallery? Does this require a phone call to the doctor or a comment on the report? Dr. Nowicki. Oh, all right.
Oh, jeez. Sure. Yeah. Well, I was just going to say we put in a comment, you know, in those cases saying, you know, not for treatment, you know, some verbiage. Yeah.
Thank you. And I've heard a lot of people do that before. All right. That's enough of that one.
All right, next case study, 64-year-old female, internal medicine unit. This is a catheterized urine. Some small colonies on there. Zoomed in a little bit. Yeast, we're looking at yeast on this one. What, do you identify yeast from a urine culture? We ignore it, we just call it yeast. We only identify Candida albicans. We only identify Candida glabrata. We identify both.
Heather, we have about 5 minutes.
Okay.
Just to let you know.
So it looks like we're pretty even there between B and E. So either we are identifying both, or we're just calling it yeast.
Okay. So the M35 is going to have revisions to Candida within their quickie workup type of thing. And the biggest, two big revisions. Number one, chromogenic media are going to be included now. So even though it's a rapid identification test, there's going to be allowances for the overnight chromogenic media, so that can be helpful to laboratories. And the other thing is that I think dubliniensis mention is going to be taken out of that document. Because clinically, throughout studying this, there's really no difference in the management of albicans versus dubliniensis. Next slide. Glabrata, within the M35 document, if you're an EMB user, you probably know that glabratas show up as bigger colonies than the teeny tinies that they show up on blood agar. So labs that use EMB in the whole Coke versus Pepsi, McConkey versus EMB argument, those of you using EMB could have a benefit in doing that, and then fire up a rapid trailose after that. Next slide.
All right, 35-year-old female seen in the clinic. We have a midstream urine. A little bit closer, you got your gram stain up there in the far left. Gram-positive rods up there. So this is a pure culture, greater than 100,000. Do you report a contaminant? Do you report lactobacillus species? Do you report lactobacillus with a comment that susceptibility testing isn't available? Do you check the UA first? Or you're done? Micro is done for the day.
All right, what are we doing with our lactose in pure culture? Was that a contaminant? Is that A?
A is a contaminant.
Okay.
And then we've got reporting species, and then we've got species with a comment.
So it looks like it's pretty evenly distributed.
Correct.
Okay.
It's the same thing, I think. All right. 46-year-old female seen in the clinic, a midstream urine. We got a lot of stuff going on those plates.
Those things on the bottom, yeah, that's an enterococcus on the CNA plate. Yep.
Okay. So enterococcus. Do you perform susceptibility testing on urine isolates of enterococcus species? Yes. Yes, but it's a limited panel. No, we don't see enterococcus in urine. We see it in the urine, but we don't do susceptibility testing. And didn't we already talk about Ericoccus? Agreed. Sorry if I'm cutting off your polling short. We're just running short on time. All right, so looks like an overwhelming response of answer A there, which is we do susceptibility testing on our Enterococcus species. So here's an example of a comment. there is at least a site using this comment already. Ampicillin is the drug of choice for treating enterococcal infections in the urinary tract, and then it gives some additional drugs. So instead of doing a full susceptibility, putting in a comment to guide treatment. Some other comments, we're going to kind of go through these pretty quick. So things you could put on your report to kind of help guide the provider as to when it's applicable to treat. So we've got comments there for yeast. We've got Staph saprophyticus here. Comment for Aerococcus urinae, Aerococcus viridans, your strep egalactiae there. And if you don't have time to read them, we can send you the comments. We've got some comments here, just general comments about maybe mixed flora or contaminated urines, contaminated Foleys.
I think we're going to cut off
Yep, agreed.
That's too much. Yeah.
We're running short on time, so we're going to skip some of these things. The last slides there were just urine PCR exists. There are maybe 4 vendors out there that have a urine PCR test. It's not reimbursable from Medicare, so it's very limited application right now. Obviously, it's not going to tell you contamination versus pathogen, so maybe in the future you'll see it coming our way, but I don't think it'll be anytime soon.
So it seems like the big limitation is it detects a lot of stuff, but it really doesn't tell you what is a true pathogen versus gamish.
Correct, and some of them will also report some susceptibility or resistance markers, but you don't know which bacteria it goes with. So like there may be 2 bacteria identified and there's no way to know what goes with which. And if the sensitivity information it provides is a contaminant or a pathogen. But they are out there, and I know there's some urology clinics throughout the country that are trying to dabble in this a little bit.
Thanks for hanging around with us. And does anybody have any further questions or ending questions before we hand it back over to Aaron? Thank you for your participation, by the way.